jump in, this is you know, I think part three now of our menopause hormone therapy sort of educational series. And so today we have Dr. Lauren Vestal with us from our OB/GYN department. She's a clinical associate professor in the Department of OB/GYN, and one of our great resources and experts here at KU for menopause hormone therapy. So we're just going to dive right in because I know John has a lot of great cases here and questions, but my guess is there'll be a lot coming from the chat and just the crowd as well. So cool. Thank you, Lauren, for joining us. John, I'll kick it over to you.
Okay, so just for some background, the first lecture of this was with Dr. Julia Kling, and it was us kind of exploring the change in MHT versus hormone replacement therapy and how basically the paradigm has completely shifted and gives us a lot more ability to prescribe these, a lot less uh, worries from a patient standpoint in terms of these black box warnings. And then Dr. Weinecke came and she did basically a pure Q&A with us. And it was wonderful. And we just got to ask a bunch of questions. But then this one is really what we want to do is we want to hammer out if we essentially have the ideal candidate walk through our door, what does that process look like? And I really want to dive deep into the practicalities of prescribing and switching in the middle and when to stop and like really just hammer out those specific details. And so the case starts with Sarah. She's a 54-year-old patient who presents to us 5 months after stopping her OCP of her own volition. She said she wasn't trying to get pregnant anymore. She didn't think that she had to worry about it, so she just stopped it. And she didn't think about any symptoms that she would have after stopping it. So she hasn't had any menstrual cycle since discontinuing, but she struggled immensely with hot flashes 10 times a day. She's interested in starting a combination therapy for vasomotor symptoms of some kind, and we can be really brief in this section, but I guess Dr. Vestal, so when someone comes into your office and they're talking to you about that and assume you're going to prescribe something or thinking about it, what's kind of your mental checklist of things that you need to check to make sure that they're a good candidate and a straightforward candidate for MHT?
Yeah, so great place to start. And when I see a patient like this, 54, stopped her OCPs, I think, okay, I can't definitively date her final menstrual period, which is super common and a really common kind of scenario for us to wade through. But statistically, 54, no bleeding off her OCPs, hot flashes, classic menopause symptoms. I think you can call that menopause. I don't think you need lab tests for that. Interestingly, the Menopause Society suggests providing contraception up to the age of 55 if you can't for sure know that somebody's
Mm.
in menopause. This particular patient, I would say she's probably fine staying off her OCPs and moving to combination. So when I'm thinking about that and I'm thinking, okay, what like you said, mental checklist, what do I need to do? I need to assess for any kind of absolute reasons that she shouldn't be on MHT, any absolute contraindications. I need to kind of risk stratify and figure out, is she the ideal candidate? Is she less than ideal? Where am I? So when I'm thinking through things that will give me pause, where I have to stop the discussion and like focus somewhere else, this patient doesn't have it, but undiagnosed abnormal uterine bleeding, vaginal bleeding needs to be worked up before you throw hormones on top of it, especially if it's postmenopausal. In the premenopausal, perimenopausal, that management is a little more complicated because you have to factor in periods and birth control. And you generally want to start with figuring out abnormal bleeding first, and then the menopause hormone therapy comes after that. So I think first about that. I think then about, does she have any known or suspected breast cancer, endometrial cancer? Because depending on different factors with that, that's a very individualized, nuanced discussion. I usually involve an oncology and a breast team. So under that category, I'm then thinking, okay, when was her last mammogram? Was it within the last year? Was it okay? Then I'm thinking, okay, does she have any history of VTE, DVTs, PEs? Does she have any history of stroke, any history of MI, any history of TIA? Oftentimes, these might disqualify people from MHT. Now, there's some histories that we would still be comfortable with, and those get a little murky. So you're welcome to send those on to us when it's not the straightforward, like, oh, good, great, no DVT, let's move forward. Liver impairment, I think about too. impairment or disease. It really depends on severity and type. So there's plenty of instances where it would still be safe to give somebody like that MHT. The other things, especially when I'm taking an obstetric history, I'm looking for, if she doesn't have a known thrombophilia, I've sometimes caught people who have antiphospholipid antibody syndrome, kind of based on their obstetric history with the early HELP syndrome or the fetal growth restriction, or um, so antiphospholipid antibody syndrome, thrombophilia is kind of takes us more to a non-hormonal conversation. And then I always just want to exclude pregnancy. I want to be like, okay, great, we're not pregnant, right? Okay. Let's see. So after I get through those things, and in my initial history taking, I'm also taking into account like has she had a hysterectomy? Because that takes me down, I just need estrogen if she's had hysterectomy versus, the other pathway where I need the progestin. And then risk stratification, I'm thinking, excuse me, I'm getting over a cold. I'm thinking hypertension, hyperlipidemia, diabetes. Do we have these? How well controlled are they? Obviously, you guys know better than us gynecologists know that these are kind of like additive cardiovascular risks. So we take that into account. We take into account things like migraines with aura, which directs us more to a transdermal route from an oral. We take into account other cancers they've had, their tobacco use. Um, so those are kind of, and that sounds like a lot, but a lot of that you already know when you know your patient. So you probably have a pretty good handle on a lot of that. Then I kind of sometimes I'll go through like actual formal risk assessments depending on what kind of history I'm getting from the patient. And those may include like the NIH Gale model for breast cancer risk over the next 5 years. Um, so I won't use that necessarily as an absolute prescribing cutoff, but just generally as information for me and the patient about a baseline breast cancer risk when we're talking about estrogen and progesterone, since there is a small but measurable increased risk. And we can get into nuances of different progestins and all of that if we need to. And then, but at this level, when I'm thinking about candidates and my checklist, kind of if I go back to cardiovascular risk factors, I'll do an ASCVD 10-year risk. And I noticed here recently that there's a new calculator and you have to toggle over to the 10-year pooled. I like the new calculator. It takes a lot more in that seems useful, but all of the kind of guideline based stuff for menopause is based off the 10-year pooled risk. So we don't have good, and not that the cutoffs are absolute, but we don't have good guidance on what the scores mean for menopause hormone therapy with the new one. So we're still kind of figuring that out. Um, yeah, I
We're
think,
still figuring it out too, to be
yeah.
fair.
And
Like prevent, we're still figuring out how exactly it plays into our
yeah,
decision tree. So that
yeah.
makes tons of sense.
What threshold do you use on the pooled cohort?
So less than 5% seems like, okay, MHT should be fine. I shouldn't be doing anything deleterious by adding this. Great, it's really greater than 10%, then I'm going to try to really avoid systemic MHT, or approach it incredibly cautiously after lots of discussions and probably bringing in, other specialists that are taking care of the patient.
Okay, yeah,
The,
that's
the
helpful.
per,
And that's a huge chunk of our patients that kind of
right.
fall in that pool, of
Yeah.
course. That I think that's where I think a lot of, or at least myself, that's where I get kind of caught sometimes on those cardiovascular risk. I think the other area that I've gotten tripped up recently is kind of this TIA thing, like how
Yeah.
it's oftentimes that we're not real sure on the TIA. How do you kind of think through some of the nuances of that part of the history, if that is the
Yeah, when I mentioned that, my brain went, oh, but TIAs are kind of hard because sometimes it's hard
yeah.
to know if it was a TIA. As a patient's trying to relate it to me, generally via telehealth, that's how we do a lot of our menopause visits, and trying to figure out, was it a TIA? Who did you see for that? Did they have you start any aspirin or a statin? Like, what was done? So often if I'm lucky, they've seen somebody here in our system and I can collaborate with them and I feel like at least half the time neurology tells me they think it was an atypical migraine. And then we might be more comfortable with MHT. But it is really hard, that whole TIA piece. And I'll generally, and I may be one of the more conservative in our group, but I feel uncomfortable with MHT if it was an actual TIA, which is often hard to pinpoint. But for the ASCVD, like between 5 and 10, if they're otherwise great candidates, we generally really lean on that transdermal estrogen because we have lower risks of VTE, lower risk of lipid elevations than we do with the PL.
I mean, the good thing about this patient population is it's like, I mean, women when they get to about an age of 65 kind of cross over into the threshold, regardless of their other risk factors, into that ASCVD score of 7.5% and above. You know what I mean? When you're really starting to think about statin, the prevent calculator seems to generally downtrend
Mhm.
people's risk and will give you a lower percent than the ASCVD pooled cohort would do, which so I think a lot more women probably would qualify based on the prevent calculator on the 10-year risk model. Um, so my thing is like if we control I mean if they have hyperlipidemia and they have elevated blood pressure, if you control those things well, there's probably very few women out there who actually give us pause between the ages of 55 and 65.
Yeah.
Uh, but I
I
think
agree. And I think that's what some of the guidelines don't necessarily and can't necessarily put in is if these things are well controlled, maybe it's still reasonable. And that's just part of that shared decision making and making sure they understand, the potential risks.
okay. And then Kristen had a question about a patient with, and you can go ahead and ask Dr. Gilmore.
Oh, yeah, yeah. So, can you guys hear me okay?
Mhm.
Yep.
Yeah. So I had a patient the other day so in clinic, she's like, I think 50 years old, was interested in hormonal or menopause hormonal treatment. But she's had a history of repeating her DBT. And so in the visit, I said, ooh, I don't think estrogen is going to be a good fit. I know that increases your clotting risk. I don't know about the patch. So let me think about it and check with my pharmacy team. And then we also talked about, well, maybe testosterone would be a better fit for you. I said, I know that testosterone can be helpful. I personally have prescribed it before. So let me do some research and think of it. When I was doing the research, I was just looking to see if I could find the citation. I found a paper saying that I think it was from the Menopause Society about like, hey, maybe the estrogen patch doesn't increase your clotting risk. And so it sounds like this is kind of like the ACVD risk and the prevent calculator. How do we sort all this out? It sounds like this is a current area of discussion of like, hey, how much does the estrogen patch, is it just lower clotting risk or is there no clotting risk? And is the current understanding, knowing that it could change in a couple of years, is the current understanding that if you have a patient with a DBT or a PE, you should not be prescribing estrogen patches?
Yeah, great question. You hit it on the head. This is kind of an area that's a little more gray than it used to be, right? It was super black and white just a
Yeah.
few years ago. It was just a straight, easy no. And now it really depends on provoked, non-provoked, that whole side of things. And sometimes patients aren't good historians and you don't really know.
Mm-hmm.
But it is really individualized in that way. Most of the literature that I've read and that the Menopause Society puts out is that the estrogen patch, the transdermal estrogen, may have very close to like no increased risk of VTE, which is making us a lot more comfortable. Now, that being said, it's still like a big mind shift from just like a few years ago saying no to saying here's all the estrogen you could ever want. So it feels a little funny, but there are patients who are an estrogen patch with a history of you know, a provoked, post-op DVT or
Mm-hmm.
something that, yeah, I've given estrogen patches to after the discussion. I mean, certainly not like, hey, you're totally safe, but like, hey, we think this is safer and I'm comfortable with this. The research suggests this should be okay. If you're okay with that, let's do it.
Is the in this and that we're getting into individual patients and that's hard, the whole history, so it might be hard to comment. This is a patient who was unprovoked, also a history of at least one miscarriage, if not two. And so in my mind, it's like this is a person who has real clotting risk. We've, done the whole
Yeah.
anticoagulation workup. She doesn't have any known genetic things, but this is a person who for sure has some sort of predisposition to clotting.
Yeah. Yeah.
Is that a patient that where you would then transition to? So because you're like, hey, I think that this person's higher risk than someone with a provoked DVT, would you then transition to like, hey, should we talk about testosterone for your hot flashes, or what's your next step? Or
Yeah.
you just say it's too bad, so sad, deal with it?
Well, I would probably rather than go to if we decide that estrogen is not
Yeah.
okay for her, I'd probably go to some of the non-hormonal management,
Okay.
especially, depending on what are the symptoms I'm treating. If they're vasomotor symptoms, I'm going to be much more successful with paroxetine or Veoza, Linquet, gabapentin than I would be with testosterone. The studies aren't great that testosterone is useful for vasomotor symptoms. It's really the niche of hypoactive sexual desire disorder, low libido, that works for. And just in that transdermal gel, we use a tenth of the male dose when we use it for that purpose, and we have to monitor, make sure we're not super therapeutic, all those things. But in general, I don't go to testosterone next for the vasomotor or the sleep-related things that I would normally hit with the estrogen. Especially if it's vasomotor night sweats, I can hit those really well with the non-hormonal things. Little less risky, little less lab monitoring that's necessary
Yeah.
as opposed to the testosterone lab monitoring is a little intense at first,
Mm.
and usually really well tolerated. Of course, the Veoza, the Linquet are newer, so their lack of insurance coverage right off the bat
Yeah.
sometimes is, limiting, but they work really well.
Thank you. That's super helpful. I
Yeah,
appreciate it.
totally.
I guess this kind of helps me, it kind of goes right into one of John's next points here, which I guess if the patch is the safest for our high risk patients, is that what we should go to first and foremost? And then like, how do you decide between patch versus pill versus gel versus other things? Like what are the key things in your kind of medical decision making?
Yeah, great questions. And I think it's kind of like asking gynecologists, what's your favorite birth control pill, right? There's 3,000 out there, so you'll hear a lot of different answers. But most of us are going to say patch first because the risks are lower. So why not start with something that's a lower risk? So most of us, like if I have an ideal candidate, menopausal, I'm going to say we're going to start with a transdermal patch. Personally, I like the Vivell Dot generics. They're small footprint. They usually stick well. There's not a lot of contact dermatitis that I hear feedback from patients. And so I'll usually start with a patch and then a progesterone every day. And so do you want to go into doses, or do you have questions about that side of it?
Definitely go into doses.
Okay. Oh, and I guess I could say like there are patients who are low risk, and a PO pill is still perfectly appropriate if they're like, I'm not doing that patch thing. That's fine. The gels are really cool. They're also limited by insurance coverage, so we don't have a lot of patients successfully on their gels for their estrogen. When we're talking about systemic MHT and not vaginal MHT, it's a separate thing. So doses. Usually I'm going to start everybody on a Vivell Dot 0.05 milligram. It's twice weekly. So we talk about safe patch placement and making sure they're removing their patch before putting a new one on, all that stuff that you guys know. But I'll usually start at like a 0.05, which is equivalent to taking 1 milligram of the PO estradiol. I don't use a lot of Premarin anymore, which is conjugated equine estradiol. It's a little bit harder to titrate, but this would be, if anybody's using that, this would be a dose equivalent to like that 0. What is it, 625 or something like that. That would be the equivalent dose. So it's a moderate dose, which can have maybe more bone health benefit, which is part of why we start there. If I have somebody who's incredibly nervous and wants to like start low and go slow, then okay, fine. We'll start a little bit lower. Nothing wrong with that and titrating up. As far as the progesterone part, I prefer the natural progesterone prometrium, the micronized prometrium. Um, in case you guys don't know, because I was talking to residents about this, and I was like, oh, you know what? Like practically, you guys need to know. My residents is the prometrium is micronized in peanut oil, so it's good to know if your patient has a peanut allergy before you give them that. Which, right, seems really odd.
Dude, is there a pop-up for that when you prescribe micronized progesterone?
I've never had it pop up.
Oh,
But I also
good
don't
point.
know how many times I've tried to order it on somebody with a peanut allergy listed. I don't know. But that's a
Okay.
really good question for the system, isn't it?
Yeah.
Yeah,
I mean, so many people have it. So the 0.05, the dot is that, and that is the second lowest dose, right? Doesn't isn't it 0.025 or does it start at 0.01?
there's I think a point oh 0.02, I think there's an oh 0.03, and then there's oh 0.05.
Okay.
So you can move around a little bit. We just tend to, in our group, for bone health and symptom control, that seems to be a good fit for most people. And there's little titration that seems to be needed when I start there.
Okay. And so if that's equivocal to a 1 milligram estradiol pill,
Mhm.
then it isn't an equivalent dose adjustment versus what you would do with the patch. Because I think we're all starting to get a little bit used to the patch and the dosing of the patch. But if you're on the pill or you're on the gel, is double always double, like just like the patch would be, or
Not quite.
okay,
They're a little bit tricky, and to tell you the truth, I usually look this stuff up when
okay.
I'm like, oh, okay, well, on a patch, I would go up like this. How does that, and then I'll look it up. How does that, equate if this patient has been on Premarin for decades and wants to stay on it? Okay, gosh, okay, let me think. How do I convert that to the next dose step that we're doing?
What do you use to do that conversion?
Lately, honestly, AI.
Okay,
Yeah.
great.
And then I ask it for a reference because I don't trust it yet.
Yeah.
What was the dose of the progesterone? I missed that.
Yeah, so for the prometrium, this is a great question. It has always been kind of standard 100 milligrams QHS because, right, sometimes it makes people sleepy. Um, so at the Menopause Society meeting in October of this past year, there was some papers presented and some expert opinion presented that if we're using the patch at point um, 0.05, perhaps we really need that prometrium to be 200 milligrams. So, as a practice, we've decided that if we're prescribing a patch or an equivalent of 0.05, we're going to do that with Prometrium 200 milligrams a night. So, that's been a kind of a practice change. We're seeing less breakthrough bleeding with that, and the studies suggest it protects the endometrium better, which is why we've decided to make that change.
And is there anybody that we would just give just that patch to? Or if we're pulling the patch, do we always?
Right. So, excellent question. The only people that get a patch only are people who don't have a uterus anymore.
Okay.
Okay. So regardless of age, regardless of if they had an endometrial ablation, if the uterus is there, then it needs the progestin to protect it, which may come to another of the questions, is the progesterone IUD? What if they're using one of those? Um, so the answer to that is great. Glad they're using good birth control, good, bleeding control, but it depends on what that IUD is and how old it is. So the best evidence is for the Mirena IUD. The Liletta should be the same, but the evidence is strongest for Mirena. It's off-label to use it for endometrial protection with MHT, but we use it for 5 years. So if the Mirena IUD, if you can confirm patients like, yes, it's a Mirena, I had it placed 2 years ago, I want to start the patch now. And you do your risk assessments, yeah, throw a patch on her, but she needs the IUD exchanged at the 5 year mark. So that is extrapolated from the FDA approval of the Mirena for 5 years for abnormal uterine bleeding control. So we extrapolate that if it's good enough progestin for 5 years to suppress the endometrium to not bleed, then it's good enough to use off-label to suppress the endometrium from proliferation with MHT. It's used internationally for 5 years for endometrial protection, so we just kind of carrying that over here to the US. But if they have a copper IUD, a Kyleena, or a Skyla, those aren't appropriate and they need the progesterone on top. Or if they have an IUD that's over 5 years, then I'll start them on their Prometrium until they can come in and get it exchanged.
And is there any between the 100 and 200 micronized progesterone, is there any difference in breast cancer risk between these two doses?
So not that has shown any promise for being something to be worried about. There is some signal difference in the studies for the synthetic progestins, like norethindrone, I'm blanking, all the other ones, agestin. But sometimes I'll switch to those if I'm dealing with a lot of breakthrough bleeding, because they suppress bleeding a little better than Prometrium does. There's so many different progestins and they all have different activity in different areas, and do different jobs better. So
And like whenever you're starting these medications and they're so ready, how do you counsel them on, hey, here's what to expect in the first few months. Here may
yeah,
be maybe the things you won't love so much
yeah.
with both estrogen and progesterone.
Yeah. So generally, we talk about how it may take a good 6 weeks to see full effect. I didn't used to see people back 3 months after I started. It was just like, okay, let me know how it goes. Let me know if you need me. I see them back at 3 months now, which seems like a good little spot. So we can talk about any issues they've had and things. But I really think expectation setting is so important. I know you guys in primary care get that. So I like to set the expectation that this isn't going to be, like a cure-all. It's going to take some time. We expect about a 75% reduction in their vasomotor symptoms. We don't necessarily expect them to go all the way, although we would like that. I tell them all that if they have a uterus and we're using the estrogen and progestin, they need to make sure that if that estrogen patch is on or they're taking their estrogen pill every day, that they're also taking their progestin. Um, a lot of patients come to me and they're like, "Oh, well, I just ran out of that progesterone pill, but I still have my patches." It's like, "Oh, please don't do that." Um, but early on, I warn them all if they have a uterus, there's an increased risk of having some bleeding. Maybe they've been menopausal for 2 years, they've had no bleeding, so I just let them know, "Hey, that may happen." It's generally light, it's generally unscheduled, and it generally stops by 5 to 6 months. If it persists beyond 6 months or it's particularly heavy, like big, heavy period flow, that needs to be assessed, right? Send those on to us, grab a pelvic ultrasound, and then we'll see them and biopsy them. That, ACOG has changed the recommendation. All postmenopausal bleeding now needs tissue sampling and ultrasound, which is what it was when I was a resident. So it's funny to just see the pendulum go. But getting a little off topic, other things that I warn them about is they may have some breast tenderness early on. Sometimes there may be a little bit of water retention, and these things generally settle out. There's not a whole lot of side effects that we hear back from our patients about. Usually, when I see them at 3 months, they're like beaming and excited and they feel great, and it's just the best. But those are kind of the big ones that we hear.
So, if you are on the 200 microgram, do people ever complain about feeling groggy in the morning or anything like that?
I've had one patient in the past 3 years.
That's
She just,
unacceptable.
yeah, she doesn't tolerate it. She didn't
Okay.
tolerate 100. We went to synthetic. She refused to have an IUD. Like we're still working through it.
Okay. And when you're prescribing these medications for vasomotor symptoms, and I mean, what else are you monitoring in terms of symptom burden to make you say we need to go up or down on the dose? If someone has an amazing, robust response and they completely went away, do you go down to a lower dose to see if maybe they tolerate a lower dose?
Yeah, great question. I think in my training, that's what I would have been trained to do, so I completely understand that. I would leave them on the same dose. They're doing great. They have great bone protection with a moderate dose. If they haven't developed any new risk factors in the 3 months, then great. Let's just keep going. And then, we individualize all of those things. So I tell them we meet annually, not just to go through your risks and make sure that it's still safe, but also make sure it's still doing what you want it to do. If the patient's like, I'm starting to get a little nervous, what if we try going lower? Sure, let's go lower.
I had a very remarkable question that just left my mind. Darn.
Go get it.
Can I
I'm
jump
ready.
in, John? This is going, maybe this is getting ahead of ourselves, so you can tell me we can do this later, but I feel like I've had several patients recently that are older patients, as like, or maybe it's like time, like, when do we stop it? Well, let's say they've been on this for a while. Is there a time that we need to think about stopping this, and like an age or something like that, or what's the upper limit? And then like kind of the similar question is the upper limit of when you would think it's safe to start somebody on metabolic
Yeah.
therapy.
Yeah, those are important factors and ones that have gone through big major change over the past even 5 years, I'd say even 2 years. So starting MHT is safest within 10 years of menopause. So 10 years of the final menstrual period, or somebody who you can't date that, you do your best to figure out when vasomotor symptoms started and see what you can figure out. So within 10 years of the final period, and or those who are under 60. So if her final menstrual period was at age 59 and she's 62, she's still maybe a good candidate based on age because her reproductive lifespan was a little bit longer. That's okay. But so I don't know if you guys get this, but it's not uncommon for me to get, a late 60s, mid 70s, never was on hormones, not having any menopause symptoms like vasomotor symptoms. Like, I think I missed out on doing hormones. Could I start them now? And, that's a really good discussion because the answer is generally no. If you're not within 10 years of your final period or under 60, then I know that we have good evidence that if I start you on menopause hormone therapy now, I'm actually increasing your cardiovascular disease risk and increasing your risk of dementia. And the studies are pretty clear on that. So we don't start them if they don't fulfill that within 10 years of final menstrual period or under 60. As far as when to stop, right, even a few years ago, it was like 65. They need to be stopped at 65. And it's much more individualized now. If the patient remains a good candidate and you do your annual kind of assessment of their risks and they want to be on it and they're getting benefit, then, often we'll keep them on it. If you have patients coming to you and they've been on it for a long time and they're like 72 and they're still healthy, you can't really say like, okay, you haven't had a stroke, you don't have anything going on that makes me worry except for your age. And they're on oral, those are ones I'm like, could I get you to switch to a transdermal? And then maybe at some point we talk about what if we just try and take you off and see how you do? You might not have, any symptoms. And I think we've all been so risk averse that sometimes we forget that there's big benefits beyond vasomotor symptoms, right? There's bone health, all those things. So we try to really weigh those individually.
If you pull someone off of the MHT, my voice is like getting worse by the second. If you pull someone off of MHT, how long should you give it before you say, okay, you truly are still having symptoms and maybe it is reasonable to continue? Because I would assume you stop estrogen on anyone, they're all going to like rebound in some way. And I don't know
Yeah,
how long that's going to take for them to kind of go more towards their normal steady state.
yeah. And that's always a tough one because they're so individual. It's hard. Shockingly, they don't all have the rebound that you would expect. Most of them do, though. And there's in the studies, there's no difference to tapering off versus just cold turkeying it. So I have patients who are like, I'll feel better if I taper it. It's like, great, taper it. Works for me. And then we give it a few months and we see.
Do you have to taper progesterone? Like if you're on 200, you have to go to 100 as well,
No,
or
that one you can just
that's what I
stop.
thought.
But yeah, if
Perfect.
they're if they want to taper their estrogen, I just have them continue their progesterone until the estrogen is no longer being used.
Okay.
Yeah.
I think another big question around menopausal treatment, and it kind of fits into this, but how often can you just get away with um, like estrogen patch or something like that for patients who have genitourinary symptoms of menopause?
Yeah, so if they have GSM, which is way easier to say than you saying the whole term, um, vaginal estrogen cream is the mainstay. It's going to be more effective than you giving them the estrogen patch. So first up, anytime I see somebody who's even describing GSM symptoms, even on telehealth, and are in the right age range for me to be like, oh, this is probably what's going on, I'll talk to them about vaginal estrogen cream and that doesn't have the same risks as systemic MHT, and it doesn't have the same list of people who can't have it. That basically anybody can have that. We joke that maybe it should just be available over the counter, but there are people who shouldn't have it. Not all breast cancer survivors should have it. Endometrial cancer survivors, people with undiagnosed genital bleeding shouldn't have it. But other than that, that's a mainstay. And my go-to is usually the estrace vaginal cream. It's pretty affordable. It's easy to find. Back in the day, it was Premarin. I don't really have a preference other than estrace is cheaper and way easier to find.
Yeah, we're like big cost plus people, Mark Cuban's cost plus, and it's $15 for
Yeah.
a tube or something like that. I mean, it's just so much
Yeah.
cheaper than Premarin.
Yeah.
And
And
so yeah,
I
go ahead.
think, not to interrupt you, but I think the hard part with the vaginal estrogen cream is making sure patients understand it's a maintenance med.
Mm,
They're going to ramp it up. There's many ways to do that. I have them do it like every night for 2 weeks, and then I have them take it down to 2 or 3 times a week. The applicator inside the vagina, and then a little bit on the vaginal opening on the vulva, and just reminding them that's maintenance meds. You're just on this 2 or 3 times a week, here on out, as long as you want those tissues to feel better.
yeah. My women never mind being on it because they get such like immense benefit from it.
Yeah.
And so I've never had a problem keeping them on it, which is a great thing to have, I guess. But now I think one of the newer things that we're not used to using, but I know we should be thinking about it, is the DHEA cream
Mhm.
for kind of similar symptoms. Like when would we be reaching for that? And are like application instructions generally similar?
Yeah. Yeah, they're similar. I don't prescribe a whole lot of it, which is funny because most people do really well on the estrogen cream. Sometimes we just change the estrogen vehicle if they're like, oh, the cream's so messy, I don't like to use it. It's like, fine, let's use a Vagifem tablet or something. So I use the DHEA stuff, the Intrarosa, on occasion, for patients who just, man, we've really optimized their vaginal estrogen. Maybe they're also on systemic MHT, and we've really optimized these things. They're using them well, and they're just not getting the effect. Then I'll change over. Off the top of my head, I don't remember. I feel like it might be daily application of that one. There's things that my brain at this stage of my life just doesn't hold in anymore, but I think that one might be daily. There's lack of data for that one in breast cancer survivors or people who are at high risk of VTE. So I always kind of just keep that in the back of my mind.
Okay, perfect. Well, so I think just kind of rounding out this case, Brandon, unless you had anything else that we needed to touch on from the previous stuff.
I I think we hit it, and I believe the questions are from the chat are answered. And so yeah, I mean, I think the stuff that we get really hung up on is the risk factors, who to screen, who shouldn't, basically. And I think we covered that in good detail, and especially some of the nuances around the ASCVD risk and some of that sort of stuff. And I think we hit on patch is preferable for the estrogen patch, and then that progesterone, combining that with micronized progesterone, but a higher dose. And I don't, I bet my guess is most of us have not
Yeah.
been doing that.
Right.
Well, and like I said, that's not like a strict guideline. That's kind of been expert opinion, and there's some studies, and we've decided to adopt that in our practice.
Yeah. And then that's really, if I heard you right on that, Lauren, the main benefit of the higher progesterone is to reduce some of the bleeding, the breakthrough bleeding.
Yeah.
Right.
Yeah. Protect the endometrium a little bit better. And then the side effect of that is less bleeding. Certainly send us, you can send a routine gynecology. Anybody who's bleeding beyond those 6 months that is just troublesome, feel free to send us and we'll work those up and get them back to you. Because those can be kind of rough,
Yeah.
even, yeah, for all of us.
Yeah.
The last kind of part of this is, I have Sarah. She doesn't see you for another year, and she comes back and
Oh
she's
yeah.
like, I feel so amazing. And you're like, what happened? And she says, I went to a clinic outside and I took a pellet. We've touched on this before. And Dr. Weinecke really gave a nice kind of overview of her thoughts about it, but I think it's just so important. Just like, how do you counsel people on pellets? And then how do you transition them to safe hormone replacement or
Yeah.
MHT after a pellet?
Yeah, and that's a real common issue right now because so many places have popped up that are talking about customized, personalized formulations, and people do feel amazing on their pellets, and they often don't know what is in their pellets, and which is a little bit harder to counsel if you don't know what they're getting. Um, I'm gonna see if I can like channel being in front of a patient. I think I usually start that conversation somewhere around trying to, not accuse them of being terrible people by doing this. But really like, completely understanding that you were having these issues, you were looking for help, and this help was available to you. And so you went and got it, and they told you all the amazing things they could do for you, and they did it, and you feel great. So why do I have a problem with it? So we talk a lot about how those pellets, unfortunately, they're not FDA approved, they're not regulated. And so I tell them I'm worried that I don't really know how much you're getting of each of the things in your pellet. I'm worried that I don't really know the purity of what's in there, that if they say that it's estrogen, that it really is estrogen and it doesn't have other things in there. They're compounded, so they're not regulated that way. I talk about the fact that those pellets generally overshoot and lead to supratherapeutic exposure of these hormones, and that really increases their risks of side effects. And when they're using testosterone pellets, we talk a lot about how really moving into that super therapeutic male range or high male range is part of why they feel so good. They get this nice like steroid effect almost. But that can lead them to some of those irreversible side effects. And then we kind of get into those. I talked to them about with these variations and not knowing how much they're really getting, that their endometrial lining is really at risk, that it's not clear that the body is absorbing progesterone from these pellets. We know that transdermal progesterone isn't effective, and a lot of people are using pellets and these like progesterone creams that are getting compounded, so they're not getting endometrial protection. And I talk about that and the uterine cancer risk. I talk a lot about how just those limitations of all these blood and saliva tests and the terms estrogen dominant and progesterone dominant, and that none of this has been proven to be safe or effective. There's not good long-term data. And that on the contrary, like if you look at FDA approved medications, that this is so well studied that we have so much data on the safety and being able to minutely change and titrate our doses and know exactly what's happening. And if we're having side effects, we generally can pinpoint, oh, it was probably this, instead of the kind of unknown slurry of stuff in these pellets, which maybe I'd say in a kind of a different way in front of a patient. Um, so if I get their buy-in that this is maybe not the safest thing, but they were trying something, they're on board to try something safer. They understand why maybe this is something that if I didn't hadn't worked on my poker face, I would be like, oh my gosh, no, don't do this. Like I see so much cancer on these patients. If I can get their buy-in, then we talk about, also, I don't know how long these last. Since we don't really know how much is in them, how pure they are, how potent they are, how much your body's actually absorbing. For pellets, for troches, for injections, like we don't know. We think they wear off in 3 to 6 months, but everybody's metabolism is different, right? We don't know. So during that time, I make sure that they have adequate progestin if they have a uterus, because I need to make sure that I'm protecting their endometrium because now they've come to me about it. And so I'm like, okay, well, at the very least, if we have buy-in to stop while we're waiting for them to wear out, I need you to take this prometrium. I'll probably do 200 milligrams because you're probably super therapeutic on your estradiol. I don't necessarily check labs. Um, I'll generally wait that 3 to 6 months and be guided by when do their symptoms return. If they started these for vasomotor symptoms and they're gone, when are they coming back? If they're coming back, then we're probably in a good washout period. And then we'll probably go transdermal estrogen, PO prometrium, and go from there. We just really kind of want to prevent adding that FDA approved estrogen on top of like a super active pellet. It's like, gosh, how much estrogen are you getting? I have no idea, and then the side effects are crazy and people are crying all the time, and it's not a whole lot of fun. And then they blame your patch and it's like it wasn't the patch. Okay. um, that's kind of how I think of it and how I look at it, if that's helpful.
That is really helpful. Do you tell people like we're putting you on relatively smaller doses, like it may take an adjustment period, even if we
Hmm.
get you on good stable doses, like may not
Yeah.
feel quite the
Yeah.
best for a little bit. Okay.
Yeah,
Uh,
yeah, totally. That managing expectations, that there may be a period of transition where you don't feel your best. We may have to titrate around a little bit to find the right thing. You may start bleeding because your body's been exposed to all of this. It may be a little bit wonky, but at some point you were going to have to come off those anyways, because
okay.
most people can't afford them in perpetuity because they're super expensive. Um,
Yeah, and I love like I mean like our biggest thing is like we want like if people go to these clinics, I always say like if you go to them like just please let me know. Like I'm never
Yeah,
gonna judge you. Like always let me know. And then
yeah.
like I always say let me know what you're being put on. And I think just knowing like feel comfortable to put them on Prometrium, especially as they're coming off, is like so it could be life-saving.
Yeah, it can be. And, I don't know. There's not great studies about any of this stuff, of course.
Yeah.
But that's kind of my take on it.
Okay. Um, we have two, I think, excellent questions to round it off. One of them we've touched on before, but it's just so high yield, and we've kind of mentioned it before. Um, and then I'll get to the other question after is um, in people who are looking to transition, and Sam, let me know if I'm not saying this right. If it's unclear, they are near slide. Okay, so in patients who have had their uterus removed, when you were looking at starting at MHT, they're not certain whether or not they're like really menopausal hormonally. Like, what are you doing in that situation to work them up and to safely start MHT, I
Okay.
suppose?
So somebody who's had a hysterectomy, uterus is gone, they're coming because maybe they're having hot flashes, the early morning awakenings, the brain fog, the classic stuff.
Mhm.
Um, that's kind of all I need is those two pieces. And then I'll do my risk assessments. As far as I'll still do breast cancer risk assessment, I'll still do the ASCVD pooled cohort. I'll still do all that jazz. I don't talk, I talk about, hey, so this is much more simple for you because I don't need progesterone. And I talk about how estrogen's for your symptoms. Progesterone is really just to protect your uterus. Your uterus is gone. So we are going to put that piece aside. And it's so much simpler, right? Because we don't have increased risk of breast cancer in an estrogen only population. So I mention that. And then we just pop a patch on them and see them in 3 months and then see them yearly and titrate if we need to. But they're pretty simple compared to people with a uterus
Okay.
and
And
MHT.
again, we've touched on this before, but someone who is perimenopausal versus menopausal in that situation, so difficult to tell. But like,
Yeah.
are there ever time? Is there like an age cutoff where you say like I'm going to reach for an OCP like slightly higher doses of these things, or not maybe not
Yeah.
combined, but like a higher dose versus like no, we're going to do MHT and use kind of these lower, safer doses.
Yeah, so great question. All great questions. So it is super nuanced and everything. I think combined oral contraceptives are great MHTs in the perimenopausal space. They provide good predictable bleeding, or you can take them continuously and not have the bleeding. Great contraception. And if you choose a higher dose, like a 30 microgram or 35 microgram pill, you're getting good MHT from that. I think a lot of the time, and I know my residents feel this way, if you have somebody in their 40s on a birth control pill, you've made sure that it's safe for them, right? They're not hypertensive, they don't have migraines with aura, like all the things. And then they're like, I got to put them on the lowest dose. It's like, actually, a higher dose will probably work better for them and control their perimenopausal symptoms. So like a Sprintec or something that's a 30 or 35 microgram or going to, and I always mix these up, Nextstellis and Natasia. One of them is ethinyl estradiol, the traditional one with drospirenone, and the other one is an E4. So estradiol is an E2 and it's an E4 and I like that one a whole lot. I can't get into all the science about it, but see, I'm not that smart. But it seems to work really well. It's just limited by being brand name only right now. But I do love a COC and I'll usually do that up until we get to the average age of menopause, 51 and a half. And then at that point, depending on patient's history, I will, transition to MHT. So
Okay.
roundabout, I hopefully answered that question.
Yeah, you did. Could you say the name of those? Uh,
Again, they're both ins, and my brain can't remember which is which, but they're both great pills. Nextstellis and Natasia. I can Google it really quick on my other screen here. I don't remember which is which.
That sounds good. I think while you're doing that, there's
Yeah.
a simple question like if someone has bariatric surgery or celiac disease or ulcerative colitis or Crohn's or whatever, any concerns for absorption, are you worried about micronized progesterone in those patients, or do you feel like is there data to say it gets absorbed adequately and has effects?
So great question. A lot of those, if they're perimenopausal, For that reason, I will steer towards maybe doing a Mirena, so I don't have to worry about that side of it. And talking through that, a lot of people are comfortable with that, not everybody. Uh, and so, excuse me, I'm not sure that I'm aware of any good quality research recently, and this may just be a blind spot in my knowledge right now. If there's good evidence about the permetrium absorption in those patients, but it's something that I definitely think about, and sometimes I'll see, okay, maybe I'm going to give you 200 because maybe you'll absorb some of that rather than 100. And if you're not having breakthrough bleeding, I might feel pretty good about it.
Mm. Okay. Yeah, we do things in medicine a lot off vibes at times. So we love
Yeah,
to use data when we can, but it's not, you don't have a study for everything. So,
yeah.
okay. Last question, as we like, I feel like this is appropriate ending with like an internal medicine, family medicine group, but is there any clear evidence on increased ASCVD risk, like what percent more events people will have based on their pooled cohort equation? Like, I think the big question is if someone is moderate to high risk and you have a good risk benefit discussion with them, I mean, is there data to suggest you will have X number more events per this many patient years? This is unfair because I did not prep you for this question.
Yeah, no, I could look into that one for you, but cold, no, I would say I'm not aware of any. I want that info too. Patients ask that. They're like, okay, well, if I'm already like if my score puts me in that and I do estrogen, like what is my score now? It's like, well, unfortunately, the calculator doesn't tell me that. I don't know.
Okay, perfect. That's fine.
And I feel similar, like the cardiac calcium scores, we use those too. That's a little bit hard because there's not, as you guys probably are like finding in regular non-menopause hormone care, like there's no strict guidelines. We don't know yet.
That was going to be a question anyway. So was the
Yeah.
CACs or like CT scan? And we talked about this before,
Yeah.
but like it's just like nebulous. And I feel like a score of 100, something that I might put someone on aspirin for, I would
Yeah.
say probably not a great idea
Yeah.
to be
And
on hormone.
and that's kind of our take on it from what literature that's out there suggests is maybe a score of 100 or more we should be
Okay,
using caution or considering other things. But again, not like a strong cutoff. We don't have those yet.
okay. Um, okay. That's all we got for you. We will stop pestering you, Dr.
No,
Vestal.
this is a great conversation.
Yeah,
Any
we
other questions? I mean, I looked it up. Nextstellis is the one with the E4 with the estetrol, and it's paired with drospirenone. Natasia is an estradiol valerate, which converts to bioidentical estrogen inside the body. So I like both of those. I just can never remember which is which, and I always look it up.
okay. If there's no other questions, we can't thank you enough for your time. We love your guys' clinic. You guys do such amazing work.
Well,
And
we're
let
so
us
lucky to
know.
have you guys. You have them like all teed up, and then here they come, and you're like, "You have a primary care, right?" And then you like glance over, like, "Oh, good, thank goodness." Okay.
Good. Okay. Dr. Polsak, do you have a question?
Oh, yes, sorry, quick question. For the Mint clinic, would you clarify, is that MINT? Is it MNT? Is it just a straight gynecology referral and we put
Oh, great
MNT? Like,
question. Yeah.
yes.
MINT. I
Okay.
forget what we decided it stands for, like midlife intimacy something. It stands for something. And I think it's its own referral. But also just putting in a routine gyne and writing mint in there is fine too.
Okay.
Because
Wonderful.
often, the other gynecologists can and do menopause, and when it gets a little murky, that's what we're there for. But I never mind seeing somebody that's less than murky. That's fantastic too.
That's the goal, right? Is we're only sending you the murky cases. We don't want to
Yeah,
send you anything straightforward
yeah.
anymore.
We want you guys to be confident in
Yeah.
things that that don't need us, and we're there
Yeah.
when you do.
Thank you so much, Dr. Fessel. Appreciate your time.
Yeah, thank you guys.
Thanks, everyone. Bye.
Bye.